a medical student here at the Health Sciences Center. We'll be presenting today's case with Dr. Firdos.
Epilepsy in women's health. So I'm going to be presenting 2 cases, and then I'll hand it off to Dr. Firdos for the didactic portion of the lecture. Okay, so this was the first patient. It was a follow-up, and the chief complaint was a seizure. The patient was 20 years old, diagnosed with generalized epilepsy, and at age 13 years old. She is currently taking lamotrigine twice a day, fairly controlled. And she stated that she had one of these seizures in November and 2 in December. She associated these seizures with stress and vaping, and she stated that she is not on contraceptives. To go in more detail, the one in November, she was alone by herself and does not remember what happened. She woke up with tongue and teeth lacerations. However, she denied any bowel or bladder control issues. The second, in December, she does not remember the first seizure. But that second seizure was witnessed by her father. Her father stated that the seizure lasted 2.5 minutes, and there was post-ictal confusion. She denies biting her tongue, denies bowel or bladder control issues as well. So just to mention some epilepsy risk factors, her prior medical history, so she had generalized tonic-clonic seizures and myoclonic seizures, as well as absence seizures. The patient stated that the first seizure episode was when she was 13 years old. Before that first generalized tonic-clonic seizure, she presented with episodes of upper extremity jerking. There was more on her right side than her left side. The medications that she's currently on, obviously lamotrigine, buspirone, ferrous sulfate, folic acid, and sertraline. And the longest period of time that she remained seizure-free was 3 months. And then some pertinent social history is that she does inhale marijuana almost every day. And then just some epilepsy risk factors. So several family members from her mother's side have a history of epilepsy. In terms of her previous EEG findings in 2021, she had that spike and slow wave discharges, and they lasted about 1 to 3 seconds. Some of the ictal discharges presented with a brief myoclonus of the hand. And then her review of symptoms there wasn't anything particularly extraordinary in there. Everything seemed fairly normal. As for the physical exam, as you can tell, everything seems pretty normal. There was no aphasia, no dysarthria. There was no pronator drift of her upper extremities, lower extremities. Her reflexes seemed pretty normal, and her cranial nerves test was normal as well. So for her assessment and plan, the assessment was that she had generalized epilepsy. The patient had good success with the current regimen given to her. It felt like her recent seizures were associated with increased stressors and vaping. So the plan was to, 1, continue her current medication, and we also ordered rescue midazolam spray. And then counseling is also very important. So the patient was educated on risks of taking alcohol and smoking. On her current medications, there was a driving restriction. And we also wanted to emphasize counseling when it comes to her taking contraception and if she wants to get or become pregnant in the future. So here are 2 questions that y'all should keep kind of in the back of your head. 1, what kind of contraception should be advised? And 2, if she does desire to be pregnant, should she continue taking lamotrigine? This is the second case. This was a new patient. The chief complaint was a seizure. She is an 18-year-old female with focal epilepsy, and this was diagnosed by a pediatric neurologist. She is accompanied by her mother and father, who are the primary historians. The family reports the seizure diagnosis at the age of 13. She had multiple generalized tonic-clonic seizures in the past, and the last seizure was 2 years ago. Her current medication is carbamazepine twice a day. Her previously failed, so she was on levetiracetam, but that was failed because she experienced side effects of mood change and irritability. Further describing the types of seizures, so there was type 1, there was aura, so like the feeling of a butterfly sensation in the stomach. And type 2, she had a generalized tonic-clonic seizure, which was consistent of intermittent rhythmic stiffening of arms and legs, followed by shaking, facial twitching, and drooling. And then her prior medical history was unremarkable, and her previous EEG reported left frontotemporal frequent spikes. The MRI was unremarkable, and her social history, she drinks alcohol occasionally, and she is sexually active, and it's important to note that she is currently on an oral contraceptive medication. Again, this patient's ROS was normal as well. There wasn't anything out of the ordinary. She did have a headache. Her physical examination was relatively normal, and just in terms of her HENT, and specifically the neurological aspect, everything seemed pretty normal there. Her cranial nerves were intact, and her speech was normal. So for her, the assessment is that she's an 18-year-old female with a history of focal epilepsy, which is currently well controlled with carbamazepine. And when it comes to determining the plan for her, it's important to note several questions having to do with the reproductive aspect of her visit because she is on oral contraception. So again, like what things need to be discussed during this visit is how would you kind of tailor the comprehensive reproductive counseling, contraception, and pregnancy. And then here are a list of questions that you all should consider that we will address, especially with Dr. Ferdows's didactic portion. So is her current contraception effective while taking carbamazepine? Should her anti-seizure medication be changed? What counseling is needed regarding future pregnancy? What folic acid dose should she take? And then how should we balance the seizure control versus the teratogenic risk? And before I hand it off to Dr. Ferros, we wanted to kind of mention the benefits of telemedicine, especially with patients that are experiencing seizures. For example, this supports women before pregnancy even begins. So telemedicine allows us to, makes it easier for women with epilepsy to talk to their neurologist early, adjust medication safely, and limit the amount of in-person visits that need to occur. It also makes a high-risk pregnancy care more manageable. So because anti-seizure medications often need frequent dose changes during pregnancy, virtual visits allow frequent check-ins and lab reviews without the stress of constant travel. And as I mentioned, when the patients were restricted from driving, so this is especially useful in that case. This also expands access to specialists. Many women don't live near epilepsy centers and specialists, so telemedicine connects them to expert care that can reduce seizure risks and protect both the mother and the baby. We can also provide reassurance during vulnerable moments, and especially in those moments, it's not always feasible to drive all the way to the specialist. It helps new mothers stay safe. We can address mental care needs as they are at a higher risk for depression and anxiety. We can also reduce the stress for mothers of children with epilepsy, so it decreases the burden of frequent appointments for mothers as well. And finally, we can remove practical barriers to care, so transportation, childcare, and work-related challenges as well. Okay, now I'm going to introduce Dr. Janatul Ferdos. She is an associate professor of neurology and epilepsy, and she is an associate residency program director here. So please give me a hand in welcoming Dr. Ferdos.
Thank you very much. So I'm going to talk today about women's health in epilepsy. Epilepsy is kind of the barrier. And then when it comes to terms with the women's, means it's more complicated because they are the future mom. So we have to take care of the patient as well as the safe baby. Plus, any point of the epilepsy, that is also very relevant because it fluctuates with the hormonal level as well. So when we talk about the woman with epilepsy, do you hear me well? Or, good? Okay. So we can categorize multiple things. Number one is the catamenial epilepsy. That means this epilepsy is related to hormonal fluctuation close to your menstrual period. Then hormone and contraception, because that also important when they don't want to get their baby. So contraception also important when they take the anti-seizure medication. Number 2 is the reproductive and sexual dysfunction. It also depends the epilepsy itself as well as the medication, anti-seizure medication. Pregnancy as lactation is also the huge things. Menopause and bone health also related to the anti-seizure medication. Then mental health as well. So today I will not be able to cover all of domain. However, I would like to discuss about the hormone and contraception and pregnancy and lactation part. So before I go to the topics, because from the physical exam and the H&P, we found several things. One is seizure, another is epilepsy. What is the difference between seizure and epilepsy? So seizure is the event and epilepsy is a disease. So we have to get the practical definition. Number one, the definition of the seizure will be, that was the research definition, 2005, that was described as a task force international against of epilepsy. And they said that epileptic seizure is a transient occurring of the sign and or symptoms due to abnormal synchronous activity of the brain. The second is the epilepsy is a disorder of the brain that enduring predisposed to generalized epileptic seizure by neurobiological, cognitive, psychological consequence of this condition. But this definition does not help with the practical purposes. Then we found the practical clinical definition that was published on ILE website, and it says that unprovoked seizure, at least 2 unprovoked seizure more than 24 hours apart. If it's within 24 hours, 2 or 3 seizure, that would not be qualified for the epilepsy. So epilepsy has to be more than 2 seizure, more than 24 hours apart, and has to be unprovoked. If it's alcohol related and drug induced in the setting of the infection, hypoglycemia, hypotension, that will not be qualified as a epilepsy. And then epilepsy can be qualified, or by definition will be the epilepsy with 1 unprovoked seizure. However, in addition to that, has risk factor to have recurrent seizure more than 60%, or there is a reflex epilepsy such as JME, you find the EEG abnormal, that will be qualified for the epilepsy with the 1 unprovoked seizure. So as I said, that there is another term we always use, the acute symptomatic seizure. Acute symptomatic seizure means within the acute insult within 1 week. If it's the more than 2 weeks or more than 1 week, it will not be qualified for the acute symptomatic seizure. The reason we need to know the acute symptomatic seizure, because that could be the provoked, symptomatic or reactive, and we need to know this, the acute symptomatic seizure, because for the long-term anti-seizure medication management, do we need to continue rest of the life, or this, because it would be the short-term etiology. Then another thing that we found on the H&P, there is a focal epilepsy and generalized epilepsy. Two different concepts. It's when we talk, we say the patient has GTC or GTC seizure. So GTC seizure does not mean this is generalized epilepsy. Generalized epilepsy by definition will be generalized onset, like idiopathic generalized or genetic epilepsy. And focal epilepsy means starting from the one part of the brain and is confined with the one part of the brain. So focal onset. Both seizure could be generalized. So if it's the focal onset become generalized, we say focal to bilateral tonic-clonic seizure. And if it's the generalized onset become a generalized tonic-clonic seizure, then we say generalized onset, generalized tonic-clonic seizure. We need to differentiate focal or generalized because the medication, some of the medication works better for focal epilepsy, some of the medication works better for generalized epilepsy. Even some medication get worse with the generalized epilepsy as well. So we need to first find out what type of epilepsy they have, focal epilepsy or generalized epilepsy. So now this is the hormone and contraception. So what is our object? First, to find out the interaction between the anti-seizure medication and oral contraceptive pill, to identify the appropriate contraceptive option for women with epilepsy based on the current evidence and guideline, to provide the practical recommendation for emergency contraception, and to highlight the importance individual counseling for contraceptive counseling and collaborative work, especially with the OBGYN. So when we talk about the contraception, it doesn't mean I'm using the contraceptive pill that is the 100% effective or not effective. We need to counseling the patients the effective contraception. What is the definition of the effective contraception? Is a highly effective contraception by definition use the contraceptive method that carries less than 10% per year failure rate. So not all contraceptive would be the effective. So we have to use the highly effective contraceptive method when patient using the anti-seizure medication. So 60%, 65% of the pregnancy in women with epilepsy were unplanned. 33.3% women use contraceptive method but not highly effective. 34.7% unintended pregnancy occurs without contraception. And 14.5% on systemic hormonal contraception with enzyme-inducing anti-seizure medication. So this is very tricky to addressing this issue because anti-seizure medication and oral contraception both has a bidirectional effect. Anti-seizure medication can interact with the anti-seizure medication. Anti-seizure medication interact with the oral contraception, and oral contraception also interact with the anti-seizure medication. So we have to find the balance, especially when there is an enzyme-inducing medication. Enzyme-inducing anti-seizure medication means that metabolize very fast the oral contraception. So what are the enzyme-inducing medication? Number one is the carbamazepine, like our second patient was on carbamazepine. So this is highly enzyme-inducing medication. Phenobarbital, phenytoin, oxcarbazepine, lamotrigine, reduced progesterone only, topiramate at higher dose, rufinamide, phenobarbital, primidone. And those are the, on our right-hand side, those medication does not interact by oral contraceptive pill, is the valproic acid, lacosamide, levetiracetam, pregabalin, zonisamide, ethosuxamide, gabapentin, rezigabin, and tiagabin. However, the valproic acid, there is a several case report as well that is also interact by the oral contraceptive pill. So the lamotrigine level decreased by oral contraceptive pill, by estrogen mainly, by glucuronidation. So if someone takes estrogen-containing oral contraceptive pill, the lamotrigine will be metabolized fast and reduce the efficacy. The valproic acid as well is reduced by the oral contraceptive pill. The valproic acid level goes down. So what are the options? Is this progesterone-only pill is the option who takes the enzyme-inducing medication? It's not, because the progesterone-only pill also dose-dependent. If they take the low dose of the progesterone, like the 30 microgram progestin, it's not benefited, it's limited efficacy because they are with the enzyme-inducing medication, so they are inducing more the progesterone. Even the intermediate dose is not effective. So only effective will be high dose, such as Depo-Provera or intramuscular injection. If we use the only progesterone in someone with enzyme-inducing anti-seizure medication. Other option is the intrauterine device. So we have two types of the intrauterine device, copper or silver or levonorgestrone. This is also recommended if someone using the enzyme-inducing medication. So those two will be the option, Depo-Provera and IUD. How about the emergency contraception? So emergency contraception, there is no data or guideline. However, the current guideline recommend little bit higher dose, like 1.5 milligram levonorgestrone instead of 0.75, means the double dose if someone using the enzyme-inducing medication. And then 12 hours later, there is a 0.75 milligram. So those are this little tiny. These are the guidelines by the CDC, WHO, American Obstetrician and Gynecologist, then Family Medicine, also Canadian gynecologist, they recommended several options. And if we see this, all the guidelines combinedly, no restriction for DMPA and intrauterine, like Depo-Provera and the intrauterine, there is no restriction. That means you can safely use from all guidelines, but rest of them are definitely, this is they use the second barrier method or cautious using those contraception because there is a failure rate is higher. So what is our take-home message? If enzyme-inducing anti-seizure medication, first choice will be either IUD or the depo-provera, depomedroxyprogesterone. If there is a second choice, could be the implant or cervical ring. However, that has to be another barrier method is additionally recommended for the second choice. If they are using non-enzyme inducing medication, there is no restriction. However, only will be the lamotrigine. If they use the lamotrigine, there should be only progesterone pill because the estrogen containing pill will metabolize fast the lamictal. So this is our take-home message. Consider bidirectional interaction between the anti-seizure medication and contraception. Prefer non-enzyme-inducing anti-seizure medication or non-hormonal contraceptive when possible. Use highly effective contraceptive method tailored the patient's need. Emergency contraception required. Adjusting dose also needed. Now back to our second patient. Patient was taking carbamazepine, or first patient, right, was taking the lamotrigine. And seizures are kind of the control. So what kind of contraception we will recommend for her? She was on lamotrigine. So if she prefers, the oral contraceptive will be the only progesterone pill, or IUD, or depo-provera. And then second patient was taking the carbamazepine. For her will be either IUD or depo-provera, because even if she takes the progesterone only pill, she needs higher dose and it's the limited efficacy. So the first patient, we said that her seizures are well controlled. What is the next step? We say switch it to the non-enzyme inducing anti-seizure medication or recommend non-hormonal contraception. I think both are the option, but let's talk about first the pregnancy and anti-seizure medication, then we'll go back to our first questions. So again, same things, the carbamazepine is the hepatic enzyme inducer. It's reduced the oral contraceptive effectiveness and increase risks of unplanned pregnancy. Now, if we move from the contraception to pregnancy, so our question was, if she plans to get pregnant 1 to 2 years, what is the best strategy? Should we switch the carbamazepine, or should we switch it to something else, or continue? What would be our plan? So the woman with the childbearing age, we have to be always consider for the future pregnancy. And our data says that during pregnancy, seizure frequency does not increase. If their seizures are well controlled, at least 11 months prior to the pregnancy, we can predict this patient's seizure will be controlled throughout the pregnancy as well. However, we need to adjust the medication during the pregnancy because there are a lot of pharmacokinetic changes occurs. Their excretion increase, their volume, blood volume also increase, so we have to adjust the medication during the pregnancy. Then also we need to consider the safe medication. The medication they should not continue because not all medication works for everybody. If that one medication works for everybody but has a higher teratogenic effect, we should avoid those medications. We should switch something else that is safer during pregnancy. And this is also very challenging because any kind of the changes, they can have breakthrough seizure. So we have to balance between the maternal and fetal safety as well as minimize the teratogenic effect as well as the seizure control during pregnancy. So that's, I just discussed, like the seizure frequency does not increase during pregnancy if we are able to closely monitor the medication dose and their blood level throughout the pregnancy and changing the dose. That will be very beneficial during the pregnancy as well. So there are several medications that is reported. When we talk to the patient about the anti-seizure medication, patient first, is my baby will be okay to continue the medication. So we can consider the two things. One is the major congenital anomaly while they're using the anti-seizure medication. So this is the study done in 1999 to 2022, almost like 23 years, observational, longitudinal, and cohort study. And then this, also the physician from the 40 different countries enrolled to the anti-seizure medication while patient was pregnant. and they follow up the offspring 1 year after birth. Their participant was the 14 to 55 years old who exposed to at least 8 frequently used anti-seizure medication, included this study, and this data was published in 2004. So from here, we see the congenital anomaly. It's too little probably, but still the first one was the carbamazepine. And we see the prevalence of the major congenital anomaly almost 5.4. Lamotrigine 3.1, the levetiracetam is 2.5, and the oxcarb is 2.9. So these three compare is the other medication looks a little bit safer or low congenital anomaly. How about the phenobarbital is also dose dependent. If they use 15 to 30, it's almost like 6.2. Topiramate, we invariably use topiramate for the migraine patient. How many times we counseling for them the pregnancy and contraception? Topiramate is also inducer with the higher dose that can reduce the oral contraceptive efficacy as well as is the teratogenic effect for the baby. But we use for the migraine, we don't counseling them. Lots of the time we use as a mood stabilizer. Psychiatric colleague uses the anti-seizure medication as well, but we don't counsel them for the pregnancy and contraception. So the topiramate also, the dose dependent, and it also causing the 4.9%. Then valproic acid is the well known for the major congenital anomaly. And even if it's the higher dose, more than 450, is 25.2% major congenital anomaly. So those are the high risk medication when you use this, except this 3 is little bit safer. Is everything is 100%? No, it's not, but this 3 is little bit safer compared to the other medication. How about the newer medication? So these are the major congenital anomaly is the cardiac, renal, neural tube, cleft plate, polydactyly, kidney, gastrointestinal, other major congenital anomaly, and then multiple major congenital anomaly. And if we see this, the valproic acid, phenytoin, topiramate, phenobarbital is the higher side. Again, carbamazepine as well. But lamotrigine, levetiracetam, and oxcarb is a little bit the lower, but it's not safe, 100%. This is the anti-seizure medication, and those are the monotherapy. It's not even the 2 or 3 medication. It's the monotherapy we found this data. And this is also, we see the chi-square also is on the all the way to the left, the oxcarb, gabapentin, and zonisamide, but rest of them is higher. Lacosamide is appeared the safe, but only we have 93 patients reported. So we have limited data regarding the lacosamide. These are the pregnancy registry. We always encourage the patient when they are pregnant using the anti-seizure medication to enroll to the pregnancy registry. And we have several pregnancy registry, United States and Canada, then Australian, Kerala, Indian is newly added, and West Chinese as well, and European registry. If we see their data combinedly also, it appears like this 3 medication kind of the saver. However, carbamazepine, the Canadian says the helpful, but other registries say it's the major congenital anomaly. So I usually try to avoid carbamazepine. So those are the newer medication. We have very limited data. We can see the zonisamide is the higher, the 240 cases, and they reported. And then the lacosamide was also a little bit lower side, but those we have limited data regarding the newer anti-seizure medication, we don't know. So those are the newer anti-seizure medication, brivaracetam, cannabinol, cenobamate, fenfluramine, lacosamide, parampamil, and zonisamide. However, among those, zonisamide, we have better profile compared to the topiramate. So those we talked about major congenital anomaly. How about the neurodevelopmental or functional outcome for the baby? That never been looked before. This is the first paper they published regarding the neurocognitive development for the baby. And I think that was 2024, the JAMA published this article. And they reviewed the 43 review study, including the population-based prospective cohort study, retrospective cohort study, and cross-sectional observational study. And the risks for the neurodevelopmental disorder in the utero exposure with the anti-seizure medication, and those are also monotherapy, is the autism spectrum disorder, intellectual disability, ADHD, social, emotional behavior, and adaptive function. With this whole paper, this is the one page, we can just see the valproic acid also, it's increased 2 to 5% of the intellectual disability, ADHD, emotional and behavioral issue, then also the poor adaptive ability. The topiramate, the next risk to have a neurocongenital, neurodevelopmental adverse effect. Phenobarbital, carbamazepine. Levetiracetam we use invariably. However, there is a one single case reported the patient can have anxiety disorder. How? But it's just the only one reported. ADHD. So pregabalin is also can causing the ADHD as well, clonazepam as well. So phenytoin and lamotrigine, we don't have any clear evidence for the neurodevelopmental. So the valproic acid increased 2 to 4-fold increased risks of the autism spectrum disorder, 2 to 5-fold of increased intellectual disability and poor productive function. The topiramate is the 2-fold increase the ADHD and the 3 to 4-fold increase the intellectual disability, 2-fold increase the ADHD as well. So both are the dose dependent, valproic acid and topiramate. So we have very limited data regarding gabapentin, pregabalin, lacosamide, zonisamide, clobazam, parampamil, ethosuxamide, Briviact. Those are lacking. Now, going back to our patients, those are taking carbamazepine. So now is the time we need to discuss. Maybe in the future, if you desire to pregnant, I prefer not to continue the carbamazepine. We prefer to switch it to something else that has a better and then low teratogenic risks. So, and that change has to be before pregnancy, not during pregnancy, because during pregnancy, always risks to have a breakthrough seizure. So we cannot change during pregnancy, we have to change it before pregnancy. And at least 11 months before, if she's stable with the new medication that predict that she will be seizure-free during the pregnancy. Now the folic acid supplement. When should we start the folic acid supplement? During pregnancy, before pregnancy, and what are the doses? And what is the benefit for the folic acid? So there is a neat study done. I think we skip the slide. This looks like. I think we skip the slide. Okay. So the folic acid supplement is important. We had a neat study, and that study definitely showed that folic acid supplement always helpful. It's not only neural tube formation, it also reduces the neurodevelopmental outcome. The patient's IQ is better compared those are exposed to folic acid and compared to those are not exposed to folic acid. So those two medications, they did the study, the patient is taking anti-seizure medication with folic acid supplement and another one without folic acid supplement. They found that the baby's IQ is much better compared non-exposed patient. So we recommend to continue the folic acid during the pregnancy, even the pre-pregnancy state, because the first 2 weeks we know they're very vital for neural tube formation. So we have to supplement with the folic acid even before pregnancy. When the patient will know they are pregnant, it's already 2 weeks gone. So neural tube formation already formed. So we always supplement in my clinic patient, they are with the anti-seizure medication. I supplement with the 1 milligram folic acid. The multivitamin has a 400 microgram, is very minimum. In addition to that, they can take 1 milligram folic acid prior to pregnancy. If they get pregnant, I increase it to 4 to 5 milligram. There is no recommendation for the doses from the study, but they recommended 0.4 to 5 milligram. I usually keep it 1 to 4 for the folic acid, and that is so important. And then also the next slide is coming. For the pregnancy, when they are pregnant, we have to change the anti-seizure medication because some of them are highly protein bounded. They're excreted through the kidney. So there is just a summary of how much is reduced the medication during the pregnancy. Such as phenobarbital is up to 55% is reduced, decreased. And the phenytoin also 60 to 70% reduced during the pregnancy. Carbamazepine, oxcarbamazepine, valproic acid, we don't continue those medication during the pregnancy, but if someone, yes, lamotrigine is reduced because during pregnancy, estrogen levels go high. So our lamotrigine level will go down. So we need to check every 4 weeks the lamotrigine level, and based on that, we have to adjust the medication. Sometimes the patients need the lamotrigine 800 to 1600 milligram during the pregnancy because it's depending on the blood level. So zonisamide usually we don't have to, but the levetiracetam very frequently used, everybody on the levetiracetam. That also excretion increase during the first and skip our slide. So that also increase. So mainly, if someone is the lamotrigine, oxcarb, or the carbamazepine, we have to check the blood level and adjust the medication. The first and third trimester is the highest risk to reduce the doses. So levetiracetam we need to adjust during the first trimester. Usually, I don't do the levetiracetam level because it doesn't predict anything. But the childbearing age, their seizures are controlled with the 1000 milligram twice a day. I usually do one blood level, just keep it as a marker. So if she gets pregnant, I can, based on that level, I can adjust the medication. Now, the next question will come. We adjusted the medication, patient become seizure free during the pregnancy. Now they delivered the baby. When to adjust the medication back? After postpartum, immediately after postpartum, within to 6 to 8 weeks, we have to change their pre-pregnancy state. So gradually we need to wean up and going back to the pre-pregnancy state. Now the question would be the breastfeeding. Because the mom is taking anti-seizure medication, should they breastfeed the baby or they need to continue not to breastfeed? When the patients comes to my clinic, they said, I was told I should not breastfeed. That's why I didn't. But here is the things. Always counseling for the breastfeeding. The breastfeeding always is the beneficial compared to non-breastfeeding. Even is secreted very negligible amount through the breast milk, but still will be beneficial. We did a study and they did the maternal blood level with the anti-seizure medication, and after breastfeeding, the fetal blood level, and they found there is a very negligible amount is found to the the child blood, and that's why we recommended for the breastfeeding. So there will be no contraindication for the breastfeeding because they are taking anti-seizure medication. Even when they are pregnant, the baby or fetus expose higher dose through the placenta compared to the breastfeeding. So there will be no questions about breastfeeding. Then we need to also counseling for the mother because after the postpartum period, we are adjusting the medication. However, there will be the sleep deprivation. There is a stress always works that will trigger the breakthrough seizure. So we have to counseling for the baby safety, especially when they're feeding. They should not feed on the couch or on the bed. They have to be on the carpet and with supervision when they breastfeed. When they give the bath, somebody should supervise because if the patient has seizure while they're giving the bath, that will be disaster. So those counsel the baby safety, and then counseling for the breastfeeding has to be in the clinic visit. Did I finish so fast? I finished so fast. I think there's some slide also. Any questions now?
Yeah. Sorry. Going back to the emergency contraception one, I've always heard that if you're at a higher weight, so if you're over, I think it's like 165 or 175, that you're supposed to take double the dose anyway. If someone is at that weight and also has a seizure disorder, is it even more or is it still double? Or?
So they did not mention about the body weight, but I think the usual dose is 0.75. And then they said if they take the enzyme-inducing medication, not the other anti-seizure medication, is the enzyme-inducing medication, they said is double dose. So If it's by body weight, if it goes higher, I think we have to go higher then, because the enzyme-inducing medication will metabolize fast. But that didn't mention about that, about the body weight things. Yes.
If the patient is on multiple medication and have a family plan in the near future, what is your strategy to manage the seizure?
So those are the major congenital anomaly when they are using the monotherapy. So when they are using the 2 or 3 anti-seizure medication, definitely the risks will go high. In that case, we have to cancel. We cannot say, don't get pregnant, don't get baby. So we have to cancel. There is a risk. We are trying to supplement with the folic acid, but there is a chance their baby may born with the congenital anomaly. And those medication kind of the safer. If you see the clinic, I usually try to use the safer medication, even pre-pregnancy period. And then if they get pregnant, we supplement with the higher folic acid and try to counseling those that baby may have the congenital anomaly. Sometimes the patient said, I will not get pregnant. I don't want to suffer. I am suffering, my baby will suffer. So those questions also goes, is it the genetic epilepsy or this is just the focal epilepsy? So it's not the inherited. Epilepsy is not the inherited, it's the genetic mutation can cause the epilepsy. So you can reassure them, this epilepsy is not inherited, you will not pass to your baby. However, there is a genetic mutation, spontaneous mutation is many different genes can cause the epilepsy. Any questions from the chat box? No question.
All right.
Okay, thank you.
Yes. Thank you, Dr. Friedel, for the great presentation. We would like to present you this challenge point.
Thank you. Thank you for everybody that's watching online and here in person. And again, all of the materials for today's session will be available on the ECHO platform. And here is the QR code as well for the CME handout. Nice night.
What are you in? Yeah, I texted